All right, can you guys hear us okay? Yes. Wonderful, wonderful, wonderful. I'm gonna sign on my computer too, and we'll get started. I think Constance is gonna give us a welcome.
Do I get to do a prayer too?
No.
No prayers. All right. So welcome everyone to today is Monday, September 23rd, 2024. We're here for our DDSN Provider Network agenda. I am tasked with giving the welcome. Recently we got some questions. There were some questions sent in. We're going to cover those questions, but some of those questions have been tasked with my responsibility. The first being review of DDSN personnel who providers will be interacting with folks who may have left. In regards to those division of areas, in regards to finance, our interim CFO, if you have any questions in regards to finance, you need to direct those questions to Mary Long, who's in the room today. Any questions in regards to engineering and planning, those questions need to be addressed to Claire Thompson. And for Claire Thompson's contact information, please reach out to Christy Lingard. I neglected to get her email and phone number. The other question that I'm responsible for are DDSN office move logistics. So as you all are aware, DDSN will be moving to 400 Oteri Parkway. From my meetings with Department of Administration has been tasked with moving all the agencies to that new location. The plan is ongoing, and as of a month ago, the plan is that we will move sometime next year, but no later than June 30th of 2025. I think that was all of mine.
Did anybody have any questions about those kind of general updates? All right, if not, I will turn it over to Margaret for the DHHS updates.
Thank you, Lori. Good afternoon. Let me see if my audio is coming through all right.
We can hear you.
Okay, great. So I also checked the suggested topics and questions, so I'm going to speak to just a few of those. So I believe there was a request, or I know that Janet is going to give some updates on RFP and pending contracts later. I will just speak to the electronic visit verification procurement. If there are any questions related to that procurement, I need to refer it directly to our procurement office here at HHS. So I'd be happy to provide that contact information, but any questions related to that procurement need to be routed through our procurement office. There was a question as well on Medicaid recertification or enrollment processes. So I wasn't quite sure if this was related to member eligibility or if it was related to a provider revalidation. So I will speak to both briefly. Provider revalidation is a process that the Medicaid agency is required to perform at intervals to ensure that Medicaid enrolled providers still meet their qualification criteria and that they have not do not have anything that would preclude them from being a Medicaid provider. This process was put on hold during the public health emergency. We are now going to be resuming that provider revalidation process. There was a bulletin issued on June 4th, 2024. It's Medicaid Bulletin 24-022 that give the basic requirements about provider revalidation. So there are specific cohorts. I'm not sure exactly where the DDSN providers, waiver providers will fall within those cohorts, but there will be a separate notification of that revalidation process. So basically just re-engaging what had been paused during the public health emergency for revalidation. So let me know if there are any further questions, if that was the intended question. There was also a question related, if this was related to members and the efforts for renewals with Medicaid eligibility. So I think Lori may speak to this in brief. There was reference to a CMS bulletin. I'm thinking that may be related to the bulletin that was issued in May out of Centers for Medicare and Medicaid Services, describing additional timeframes for unwinding activities and flexibilities. The agency has worked in concert with our partners at DDSN as those resumption of annual renewals and reviews of eligibility have occurred. We have done some adjustments along the way to ensure that we're doing everything that we can to use existing information for those renewals, as well as working to engage stakeholders. So at the end of the day, what you all as providers can help us to do is to be keyed in with what members may be receiving in terms of communication related to eligibility, assisting with individuals that may be difficult to locate or difficult to contact, to encourage them if they have received any communication or their representative parties, to help assist with getting any of that information in. And certainly we will help to coordinate between DDSN and our eligibility areas. If there are questions, specific incidents, specific members that we need to take a look at, we're absolutely happy to connect with our specialty teams and escalation teams to ensure that everything is done that can be done to ensure members complete that renewal process as they need to. Also, there was a question on the ARPA, American Rescue Plan Act spending plan. So there were many different categories of American Rescue Plan Act funding. So I expect this is related to Section 9817. That is basically the section that allowed for additional funds to be pulled down for home and community-based services. And this was funding that DDSN provided DHHS with recommendations in terms of priority areas. We in turn reviewed those priority area of recommendations and determined which of those we included in the final spending plan that was submitted to Centers for Medicare and Medicaid Services, to CMS. We also evaluated along the way, as we were going through and implementing those activities, if there needed to be any updates or changes to that plan. What we did hear very clearly from the provider community, and that is all of our HCBS home and community-based provider groups, that at that time, the biggest and most pressing issue that was of greatest concern communicated to us was hiring and retention of staff and worker shortages. So we did, as we implemented the plan, adjust some of those activities to put additional funding within the ARPA plan to rate increases. We did that to allow for some immediate actions to occur until such time as we could seek recurring funding for those rate levels through the annual budget process. So that is one area that we did utilize funding to help us until we could get to that recurring budget request to support rate actions. So we went ahead and did shift some activity and funding to that area. As many of you recall, we also implemented one-time payments for direct worker retention. So that was a component that many provider groups were collectively asking that we take into consideration as a priority. So we did implement one-time payments for retention. So from the original plan to the finalized expenditures, we took into account the feedback along the way that really directed us toward additional expenditures in support of rate actions as well as retention payments. We have fully expended our complement of ARPA funding according to the spending plan. I know that there are reports and some graphics, some slides that CMS is issuing related to the state's ARPA plans and activities and what has occurred. CMS, I believe, has issued 2 of those updates and graphics. They are based on a point in time as to when CMS had all states with fully approved quarterly report submissions and plan submissions. So please recognize that as those reports are coming out from CMS, they reflect a point in time and not current state of expenditures. So they picked a particular quarterly benchmark where all states did have their documents fully approved that they could publish. So just know that it may reflect not all spending that has occurred after that particular point in time. Also, just wanted to make mention, I can't speak to any specifics until such time as our budget request is finalized and presented to the legislature. When we made the change to fee-for-service and direct billing for waiver services, that shifted the responsibility of state match to DHHS. And we do intend to address funding for waiting lists and slot assignments. So again, I can't share specifics until such time as we have presented on the budget, but it is among the items that we have been analyzing for inclusion in the budget request. Just a reminder as well for billing issues, if this is related to services that are direct billed to Department of Health and Human Services, please know that there is the capacity to go first to our provider service center. They will open a ticket and assign you a ticket number to help us with tracking. That can be accessed through our Department of Health and Human Services website. If you go under the provider area, there is an option to contact a provider representative. And there's a phone number as well as an automated online form that you can submit to the provider service center. I generally instruct folks to go through the provider service center first. That way you do get an assignment and something that allows us to track those requests through. So that is always the first step for billing issues to be addressed. And finally, there were questions related to cost reports. So I'll take this in two separate iterations. So for the cost reports related to waiver services, we wanted to ensure that we had some experience in that shift to fee-for-service while still collecting cost reports, just to have another indicator, another mechanism to evaluate our rates against those cost reports. So we kept that in place for a period of time, again, to have that comparison point and ensure we were all comfortable with the rate models and where we landed with that. So we have not made any changes to that process. Certainly DDSN still has instructions around that. At the time that we determine we no longer need those, we will certainly communicate that in advance. But as of now, we've left it in place with no change to the format. There will be some differences as we are approaching the transition for ICF direct billing. Of course, that contemplates implementation of individual rates, which will need cost reports to support. I don't have the level of detail yet that I know you all are going to want, but that will be part of that ICF process as we are working through that project plan. I think I hit on all of the topics that I needed to. Lori, I'll turn it back over to you.
I think so too. Does anybody have any questions specific for Margaret, or you want me to keep moving? We don't have anything in the chat, so I'm going to assume no questions, no questions. So again, like Margaret said, we kind of have a list of meeting requested topics from you guys that we're trying to kind of go through. So I'm going to go through the ones that I think pertain to me. I will tell you there's a few of them I don't really understand, so I'm not sure who can help clarify like what you're wanting to know. So the first one was around an update on new or proposed directive changes. As you guys are aware, we had kind of a period of time where things were kind of up in the air around the future of whether we were going to be S915, I'll just say it that way, right? So we kind of paused on directives for a minute, but we have started that back up. We had 4 directives that went out for public comment a while ago. I think last Wednesday was the last day. Those will be presented to the commission in the October meeting. As you're aware, we did update the commission policy around directives at y'all's request, and we added it to 15 days instead of 10. So you'll be notified anytime there's an update to the directive. In addition, for directives, for some directives, we've held focus groups and tried to get information directly from providers before making changes. But many of the changes that we are making to directives are directly impacted from changes that are made to waivers or changes that are happening related to fee for service, right? So we're not over here just kind of making changes to directives, for the sake of doing it. So that's kind of my update on that. There was a topic that said CMEI updates or concerns of providers. Does somebody who submitted that topic want to kind of clarify if that's something you want us to talk about or something you want to talk about? All right, I'm going to kind of skip over that unless somebody wants to talk about it. And maybe if you send me something directly so you can explain kind of what you want this group to say about those things, we'll be glad to do that. There was a lot of questions around Medicaid recertification and the enrollment process. Margaret kind of touched on it because we were kind of unsure whether you were asking about Medicaid eligibility for the person or provider verification. So the question specifically is, how is DSN working with the Medicaid office to ensure supported folks remain eligible? So there's actually a person in my area that is monitoring the eligibility of people who are supported in waivers and people who live in ICF's IID. We have an agreement with HHS. They're sending us kind of a weekly list of anybody who looks like they're going to fall out that is a waiver participant, I don't think ICF folks are on that list. I think we just monitor that directly. So we're kind of trying to keep up and make sure that people aren't falling out of eligibility when they don't need to. I have gotten a lot of questions around who is supposed to assist the person when they get a recertification packet. And here's the thing. The person who needs to be completing that recertification packet is the rep payee or the person that's closest to that person, right? There's been a lot of question about, hey, I need the case manager to fill out this recertification packet. Well, the case manager doesn't have that information. They don't have access to bank accounts. They don't have, access to the money that the person has on hand. Now, certainly, if the person lives at home and the family is struggling knowing what to do and what forms to fill out, the case manager can help the family know what to do. but it's not a case manager's role to fill out a Medicaid application packet for somebody when they don't have that level of information. That's kind of, I think, I'm trying to address the question that says, what can case managers or providers do to assist? And then who is the contact person if we run into issues with the Medicaid office? Well, I think Margaret kind of said, you can start with the provider service center. You can contact who you got the person or their rep payee can contact who they got the packet from. And then there's questions about the deadline. So hopefully that kind of addresses any issues that you have around that. Certainly, we at DDSN are doing everything we can to try to assist with Medicaid eligibility. We don't have the availability to do that for people that are not waiver participants. So I imagine that there are people who are falling out of Medicaid that we don't know about. I've gotten involved with some that are like at PRTFs, you know. The big thing there is families just need to be reminded if they get a packet or any kind of recertification application, they need to turn it in. And then there was billing issues and fee-for-service communication issues. So from a billing perspective as providers, if you're getting claims rejected through submission to HHS, you need to speak with HHS about why those claims are being rejected and what you need to do to rectify them. There is a mechanism in TheraP that will reject claims. Basically, TheraP is not sending them to HHS, and in those circumstances, you need to contact the TheraP help desk to try to figure out what's going on with the person's record and why it won't submit. If you have questions around state-funded fee-for-service, you can contact our finance department and they can help you through those. So somebody sent me a link and said these directives are under review. That's because the review has ended for those 4 I told you about. So hopefully that clarifies. All right, I think Janet is next for operations updates.
Yeah, good afternoon, everyone. Again, we were sent a list of questions that we're trying to address. One of them was RFP/contracts pending. So Margaret addressed the EVV contract because, again, that is not DDSN, that is DHHS. So she gave you an update on that. As far as DDSN contracts or RFPs, there was a solicitation for an electronic health record. The State Fiscal Accountability Authority Division of Procurement Services is the entity in the state that controls that award. No award for that contract has been issued to date. So we're still waiting, just like you are. There was a request for proposals that was issued by DDSN some time ago. There was a little bit of struggle in getting it awarded, but it has been awarded. And that contract went to a company called EdMetric, and it is for what we commonly refer to as the acuity assessment. So there's been some desire to have an assessment of people with one of the first use of that kind of data when it goes live would be to use that information to see if there are different tiers of residential habilitation that may be appropriate. The current tiers are fairly location specific and location driven. Instead, one of the first uses of any data that would come out of the assessment tool would be to consider if changes are needed to residential habilitation tiers of service. There are a lot of uses for that information beyond that. There was an RFP for someone to do research nationwide on different, the way other states did it, the tools they used, the information like that. We've been through that process. The state has selected an instrument that is used, currently in use in Missouri. It's not really an assessment. It is a scale. So it is not something that, say, a residential habilitation provider could take, look at the results somebody got after the scale was administered and know how to write a residential support plan. It is not that. Essentially, we like to describe it as more of a discrimination tool, meaning when you go through this process, you will find a group of people who are more alike than another group of people, and they are more alike than a third group of people. So again, it's kind of discriminating between the people into, you know, I don't know, small, medium, and large, extra large, whatever. So it's kind of putting people in buckets and putting people together. So it is a scale versus a kind of, I guess a scale and an assessment can be the same thing, but for me, I'm thinking it's a scale because you're kind of measuring which group they are most alike. Anyway, so the next step for implementation of this is that we pilot the scale and make sure it's working for South Carolina. The group of people with whom we're going to be using it first, just to gather some data and make sure it's working, are those people who are currently receiving a residential support. So it could be ResHab in any tier of ResHab, or it could be an ICF, meaning a provider-operated ICF or a regional center. We're going to test it on about 500 people statewide. The test can be and is virtually administered. In order to administer the test, we really need somebody who knows the person well. I'm sure y'all have heard that about 1,000,000 times. But again, we need someone who knows the person well to accompany the person to the appointment. Most of the testing will take about 30 minutes. On average, the runtime is about 30 minutes, so from beginning to end. The way the test is set up, there's a lot of kind of opt out, meaning you don't have to ask every single question in the test bank. If so many of them are missed, then you just stop with that section and move on. So it tends to move pretty quickly. There is an entity that we will be working with to conduct this pilot and gather data. One of the things that we will be doing is we will be reaching out to residential habilitation providers and kind of talking about ways that we can get these scheduled based on the availability of the interviewers and that kind of stuff. There's just kind of a lot of details to be worked out on in that regard. Again, this is not, if you've been around for a while, DDSN's kind of done this before a time or two, but this is not the CIS. It is not anywhere near the in-depth and meticulous CIS, which is one of the reasons why it was chosen. So that is coming. That is a contract we are currently working. Much more information coming to residential habilitation providers and ways that, we're looking at ways that we can put some scheduling opportunities out for the residential rehabilitation provider versus sharing a time when it kind of needs to happen. The other thing that I'll say is that we do want the person present, but if the person briefly participates, they can leave, and the person who knows them well can respond to the majority of the questions.
There's several questions about this. You good if I just read them to you?
Sure.
How would the acuity assessment or scale impact where individuals with disabilities and leases would live? They haven't really gotten there, right? But our hope is that
We are pre-testing the assessment tool. I don't know that it would impact. My guess, and I could be wrong, I probably might be wrong, but there's some thought to hold harmless for a period of time. So if we did a scale and we identified that compared to where somebody is now, their bucket is very different, we would likely not adjust the rate that we paid for that person, because a tier is a daily rate, right? So we would likely not do that. What we're trying to do is get away from any indication of where people live. Again, the theory is that you can, with enough money and the right amount of people, you can support anybody anywhere, in theory. Right now, the tiers are very heavily tied to settings, which is sometimes impeding people. Like with a little additional support, somebody might do better in an apartment, but you kind of can't get there without a single case agreement and that kind of stuff. So I think that's farther down the road than we are in terms of a real answer to that question.
Right. Will these be in-person interviews or remote? Like Janet said, it is a virtual assessment, right? So it is going to require the use of a camera, right? A webcam, but it is a remote assessment that literally the average time they are telling us is 30 to 45 minutes. So hopefully it's not going to be too disruptive.
And the caveat to that 30 to 45 minutes is a seasoned reviewer. Correct. And initially none of the reviewers will be seasoned. So they will all be new to it. So it might take a little longer in the beginning, but we're hoping they're going to speed up, and that, we're hoping the pilot will be completed very early January.
Yeah, the question is a tentative start date. That's one of the next questions. It depends on how quickly we can
get the training.
Right.
I think we're really looking at a start date of mid-October.
Mid-November, I think. I think they're looking at training mid-October and start dating right behind it. And that is if everything falls into place exactly as it should, right? So there's a question about whether there can be one or more than one person in the interview. I think that's a question that we can ask. I mean, they typically have it set up as a person that knows them well, and the interviewer, but we can certainly ask that. And then there's a question about, would this eliminate single case agreements? So one of the preliminary meetings that we had with the state that has implemented this, right, is that this is a good tool to kind of categorize people, but there are always going to be outliers, right? Because you do have those people who are in really special, significant circumstances. Now, we do intend to include some of those outliers in the pilot so that we can get some information about what they look like in this acuity assessment. But I think it's too early to say yes or no. I just recall them saying very specifically that any kind of tool is not going to catch kind of these very extreme circumstances.
Yeah, and we don't anticipate this is going to capture every single circumstance, because we're dealing with people and it just never ever works out that way.
Right.
So, we do think that perhaps it will open the door to more options because you're not tying funding to location. So we think that's a positive outcome of that. The other thing is it might cut down on single case agreements from where we are now. We don't have a terribly lot of them, but I would think that getting a single case agreement might be for those truly exceptional people.
And then there's a question about standard time frame for revalidation. So the tool is currently being done annually in the location that's using it. They do an annual kind of a reassessment isn't it, or is it 2 years?
So in Missouri where they use it, I believe they redo it on the person
I think so too.
every 3 years.
Oh, I was thinking I knew it was
Right.
some cadence.
So that, it's not, now, obviously, if something changes, if you go from, so you're one way one day and then you have a stroke or you have a wreck or you
Right.
have a whatever, then obviously significant changes to the person. They also allow people to ask for an updated assessment, an updated scale, when there have been an events that anticipate the need for that.
And then there's a question about, will there be a certain percentage from each residential habilitation provider chosen for the pilot? So we're not
choosing providers,
Right.
we're choosing people. If that makes sense.
Right. It's around sampling from the different tiers. Because the idea behind it is to look at it during the,
Well, it's tiers and residential locations, because we're
Right.
including ICF, regional center,
Right.
ICF, community. But we've looked at the number of people, so at each tier, those in SLP 1, and ICF. So they're creating the sample around that, the total number of people in there and then pulling it out.
so this question is, will there be an opportunity to discuss the assessment recommendation before it's finalized so we can ensure all relevant data has captured? So it's not really an assessment that leads you to anything other than a category in which that person.
So right now, again, we're still piloting. We're
Right.
not to the full implementation
Right.
stage. So as part of the pilot, what we will be doing is looking at people where they are. So if we're looking at residential people, we know the payment for ICF, whether it's regional center or community ICF, and we know what tier they're currently getting. And so when we start looking at the results, we're looking to see, are there vast differences or not? And if there are, why are there vast differences for a person? So what we're trying to do is not necessarily put people in the same bucket they're in. We're not intending to have as many buckets as we have now. So we're trying to compare what's happening now to what this tool says. At the point in time of implementation, I'm sure, although we are not there yet, I'm sure that any residential habilitation recipient will have the ability to challenge or appeal a tier.
That's exactly what they're asking. Like, is
Yeah.
there a discussion about appealing the process and, but it will be the appeal of the waiver participant, right? Because
Right.
that's the person who has the appeal rights. And then it's, do we know the name of the tool?
We do, it's the
know what it stands
Missouri
for.
Adaptive,
I don't know, it's the one used in Missouri. They commonly refer to it as the MOS. It will be adapted as part of this pilot for South Carolina and will likely have another name. So we're actually working with the people who developed the MOS.
yeah, MAS,
And Norman.
MAAS.
Right.
M is Missouri, S is scale, I don't know the two A's.
Right.
We should have a contest for naming it.
Yeah, we might have a
in South-
contest for naming it in South Carolina. It
As
won't be
long as it's not the
Moss
SCOS and as long as the acronym doesn't wind up being ASS.
here. Right.
We're fine. So any more questions on that?
Mm-mm.
Kind of a lot. I guess the thing really, the takeaway is we hope that those of you who are listening that are residential habilitation providers will just kind of lean in a little bit, think about if you're called upon to be, to support someone to participate in this pilot. The quicker it goes, the quicker we get to new tiers versus the 8 and or 9, depending how you look at it now, 10 if you count ICF. So anyway, so that's that topic. So the next topic, and Margaret covered most of this, but it's on the agenda. And so I'm going to go over it. And the good thing is it's on the agenda until July of 2025. So every single month between now and July of 2025, I am going to go over this PowerPoint presentation unless somebody tells us we don't need to do that anymore. Okay? And it starts with getting the cord in your machine there. Let's see if it'll take over by chance. It is not taking over.
Uh-oh. Hold on. I think I can do something, maybe not. Can y'all see Janet's or no? Hold on.
No.
Okay, sorry. All right, Janet, I got nothing. Unless you want me
Okay,
to,
I'll
unless you
talk.
want to email it to me and I'll present it, if it'll let me.
Why don't I just talk through it this time, because we got until 2025, so I'll just, next time we'll figure out how to make the PowerPoint work, okay? So the specific question is, how is DDSN following the ARPA spending plan submitted to DHHS? So I was not intimately involved in this, so that I appreciate the question so that I could go back and kind of familiarize myself with information, just so I would know for my own personal knowledge, I guess. So there was a document that many of you have seen. It was approved by the Commission on Disabilities and Special Needs, June 30th, 2021. So it is attached to that commission packet that is on the DDSN website. This document I refer to as Attachment A, because at the top of the document it says Attachment A, 10% FMAP budget plan. That was created by DDSN. It was approved by the commission June 30th, 2021. I believe that was an emergency or a special commission meeting. It is on our website. It is an attachment.
What commission meeting was it approved at, July?
July 30, 2021. Okay? So commonly referred to as Attachment A. In early July of 2021, that document, which was DDSN's recommendations to DHHS or suggestions to DHHS about the use of this funding. What would DDSN like to see? So those recommendations were actually shared with DHHS in early July of 2021. DHHS submitted the state's statewide plan for this funding. It was submitted to CMS July 12th, 2021. It's on the DHHS website, and I do hope that you will all fact check me. So that statewide plan was submitted by DHHS to CMS on July 12th. It was a statewide plan. It was for all South Carolina home and community-based waiver programs. There are 8 home and community-based waiver programs, right? So this was for all of them, not just DDSN's waiver programs. In December, well, specifically on December 15th, 2021, DHHS advised DDSN that there were some of the things that were on Attachment A. So that Attachment A document that I was talking about, there were 3 things on that Attachment A that DHHS did not incorporate into the state's plan. So there were 3 recommendations from DDSN that DHHS did not incorporate into the state's plan for the ARPA money. Those 3 things were a program to incentivize and reward day service providers to reopen, funds for telepsychiatry response capability, program for grants to residential providers to pilot technology in lieu of staffing. Okay, so those 3 recommendations or suggestions from DDSN, which DDSN got from you all, did not actually make it into the plan. So also on December 15th, DHHS sent a crosswalk to DDSN. And that crosswalk was the state's plan and DDSN's recommendation and how what DDSN recommended was being covered in what was actually included in the state's plan. I had an example of that to show you, but you know my stuff don't work. So the state's plan had 3 areas of focus, primary areas of focus. Activities to support recruitment and retention of a robust provider network. Enhancements, that was number 1. Number 2, enhancements to HCBS services and improved access to waiver services. And number 3, quality and infrastructure improvements. Under the first primary focus group, which was recruitment and retention of a robust provider network, they put a couple of bullet points to kind of explain what the activities would be around. Workforce support and training, such as signing bonuses, retention payments, retainer payments, strengthening assessments and person-centered thinking, person-centered training, And then the second bullet was specialized payments. If you go to the DHHS website or if you go to the CMS website, there's information out there about about updates. There's regular information. It appears to be quarterly updates that the state is submitting. They are posted on the DHHS website, and the July of 2023 is on the CMS website that talks about the activity to date. Okay? So all of the updated information is out there. So when you're talking about focus area 1, recruiting a robust network of providers, the things that DHHS has done as of July of 2023, most recent I could find in a little bit of time, they increased rates for select home and community-based services. They established a provider work group to inform the approach and methodology for one-time payments. They allowed application for one-time payments, and they awarded 448 one-time supplemental workforce retention payments. The third thing is they were researching options and training certifications, including training programs for direct care and HCBS workers, and custom e-learn courses on person-centered services. So they were doing research on the options for training and certification. So that's kind of focus area 1, what they said they would do and what as of July they had done. Focus area 2 was enhancements to HCBS and improved access to waiver services. Bullets on here, additional funding to increase the number of slots available in waivers, funding for time-limited supplies and equipment to enhance access to services. And then a bullet that was HCBS waiver programs, where they talked about increasing the amount of waiver case management in the DDSN waivers, increase home accessibility adaptations for environmental modifications in the ID waiver, adding environmental modifications to the medically complex children's waiver, adding independent living skills to the DDSN waiver, extending the use of supportive technology for at-home participants in the IDRD waiver, adding in-home supports to the IDRD waiver, temporarily provide supplies such as PPE, additional support through community transition services to facilitate transition from institution to community. I believe that is the Home Again program that Medicaid operates. Increase provider capacity by using time-limited funding to provide funding for services to pursue education and certification opportunities. Sorry. And then the last one was the use of technology to improve access to care by allocating time-limited funding to cover providers and beneficiaries' telehealth startup costs. Okay, so that was kind of a mouthful. By July of 2023, they had made some amendments to the medically complex children's waiver. I will not read those. They had made some amendments or some changes to the IDRD waiver. They had added independent living skills for remote supports and group respite. They had increased service limits for waiver case management, increased the lifetime cap for environmental modification. At this point in time, they had transitioned to tiered residential habilitation. In the community supports waiver, they increased service limits for waiver case management, added options for group respite, revised annual cost cap amounts, and permanently incorporated rate increases. For the HASKI waiver, much of the same, independent living skills, remote supports, waiver case management. They added employment group, and they incorporated the rate increases. More on that same focus area, they consolidated nursing services from 2 services into 1 service and personal care from 2 services into 1 service. Participant counts were increased in the IDRD waiver renewal, and the HASKI was proposed to be increased as well. And they were going to, a projected increase in unduplicated count for the community choices waiver was incorporated into the waiver renewal. So again, all that is work that is done between the point in time that the statewide plan was submitted until the update that I was reading that was dated July of 2023. So as you can see, by July of 2023, much of the work had already been done. The last focus area was quality and infrastructure improvements. The bullets under that were enhance the implementation of quality improvement strategy, upgrade the incident management system, evaluate the need for updates to its case management system, and that is talking about the HHS case management system, and pursue electronic training platform for all HCBS providers. So HHS has started working on the new incident management system and made some progress on that. They have completed market research and had demonstrations on a case management system, again, for non-DDSN operated waivers. And then, as Margaret mentioned, they moved some money around because there were higher priorities in some areas than others. But that's the ARPA plan. So I'm going back to the question, which is, how is DDSN following the ARPA spending plans? Really hard to answer because the things that are in the state's plan have been implemented, and there's not a lot of stuff for DDSN to follow. Yes, there were waiver amendments. Yes, there were other things. So again, not a lot to follow.
Yeah, I'll say again, because I see a lot of folks in the chat have kind of put links or included the attachment A. I want to make sure that everybody clearly understands that that attachment that was approved at the commission meeting is DDSN's recommendation to HHS. That is not the final ARPA plan. The ARPA plan is what DHHS submitted and got approved to CMS that they are reporting on. So I think that's kind of the clarification that we want to make sure everybody understands. We certainly are doing things, right? Like if HHS gives additional waiver slots, we're allocating the waiver slots. We, are assisting with, we've been involved with all kinds of stuff related to the critical incident incident management system. Sorry, I called it the wrong thing. But, we've had representatives on groups and we're, certainly at the table as the operating entity, but DDSN doesn't have ARPA money to distribute based on any plan, right? So I think that's kind of the message that she's trying to,
And again, we're happy to answer any questions. We're trying to answer this question, although it's hard to understand, except to start with the fact that attachment A was recommendations. It was recommendations or suggestions that were submitted to DHHS, and the final decision about what went in or did not go in that ARPA plan was DHHS's decision to make as a state's Medicaid agency. And that's kind of where we are.
so now what I'm seeing is, I'm thinking the question is related to how DDSN or DHHS is going to follow up on the ARPA and FMAP money that was allocated to the providers. I don't know the answer to that. That's not how I read that, though. It was kind of like,
if I could project, I would show that the question was, how is DDSN following the ARPA spending plan submitted to DHHS?
right.
So the only way we know to read that is to say, start with the attachment A and go through all of it so that we have an understanding.
Go ahead, Margaret.
Thank you. So it may be helpful. I'm not sure. I see a question from Chris in the chat. Is the question really specific to the one-time payments and any follow-up on how that was utilized, or the overall plan? Because if it is about the one-time payments, I'd be glad to follow up separately. Basically, we issued those payments according to an attestation and expected uses of that funding. So it is subject to audit. There are no formal audit plans currently. Is that the question that you're really focusing in on, Chris?
Well, I didn't see the question submitted, Margaret, but I was just thinking from my perspective, I think those were some time-limited funds that were out there. And
Right.
I think maybe the ones issued from DDSN, the state director at the time allocated some of the FMAP funds the state had. And then I think ARPA also, you guys allocated some as a one-time payment. And I know in the finance world, we've been trying to discuss when does that time run out and what kind of reporting, because I think the award referred to some reports or something that might need to be done. So that was just my perspective of it, but I could be way off base.
Okay, and I would be glad to provide information on the final update that we have provided to CMS to help uh, folks if that is the intent is to better understand what was the final uh, in reinvestment that was completed. So I'll be happy to take that as a point of follow up if that's the
Could
question.
we ask, so DDSN received questions, and it was basically a set of questions copied over every month until July of 2025. I don't know who sent those questions, but whoever sent those questions,
I believe.
if those questions could be amended, then we can address that at the next one of these meetings. Because otherwise, we're going to feel compelled to go over exactly the same information that we just went over again, because it's still the same question. So if those questions could be amended and you could tell us, no, that's not what we won't go over it again, and all of that's fine. But we've got a bank of questions, some of which make perfect sense that we go over every time. We're fine with that. But a specific question like this might be better if you would tell us that it's okay to remove that question and instead answer this question.
I think it's just probably multiple layers, Janet. We have a finance group meeting tomorrow, and we can further clarify that, and I can submit an updated question through the forums email if what I'm asking is what we're looking for from the finance side. I mean, I'm sure the EDs might have a different perspective on this than what we've been talking about. I appreciate
think
that.
The questions did come from the Human Service Providers Association, so
It also came in a letter, right?
So, as far as the agenda items for this meeting, we already have agenda items until July of 2025, and it's pretty much all of the ones that we're going over today that we'll keep repeating every month unless the person or the entity that submitted it changes the questions. Okay. So the other thing that was in my update area is any concerns related to alliance surveys. I think Ann Dalton is on the line, so I'm going to ask her if she would speak to that, if she can.
Hey, Janet, I'm on. Hopefully, can you give me a thumbs up if you can hear me?
We hear you.
Perfect. So Alliant continues to follow the schedules that have been in place for the 12 to 18 month administrative compliance individual service reviews. They are also continuing with annual licensing inspections and periodic unannounced day and residential observation and participant experience surveys. So their schedule remains the same. There is a bit of an accelerated process related to the timeframes. In the past, providers have had a stretched out, elongated period between their review and the actual receipt of their report of findings. And with the RFP that was awarded this past fall, we did outline some very specific timelines and expectations for Alliant to have the report of findings back to providers. So they, the providers may experience a change with the remediation opportunity, or I'm sorry, the reconciliation opportunity coming up much faster than what they might have experienced before, because we are holding Alliant to that 30-day time frame and actually having that final report of findings back to the providers within 45 days. But that is that's the only thing that I know of that might have surprised providers. We did try to communicate that up front at the beginning as we shifted to this new contract. But if there are any questions, please feel free to reach out, enter them in the chat now. I will be presenting at the next quality management work group with the providers that will be coming up, I think, towards the end of October. But if there are any questions in the meantime, please let me know.
Thank you, Ann. That's it for me.
All right, I think, Mary, you're bringing up the rear, and I think Margaret addressed a lot of what you were going to talk about, right?
Yeah, with both the cost allocation plans and the cost reports, both of those were addressed by Margaret. They're basically under review and update by HHS at this time. So when they complete their review, they'll be sending out correspondence with the updates and new guidance. There was one question for cost reporting, is the format changing? And that's under review. It is changing, but that is, again, that's under review with HHS. And once they finish their reviews, they'll be issuing that guidance for those. So we would like for you to continue following what is currently posted out there.
All right, and then I guess the last thing on the agenda is if there are any questions or topics that we didn't cover that you guys would like to talk through. All right, I'm gonna
Lori, this is Chris.
Hey, Chris.
Do you guys have a work plan for the directives that are up next for you all to review so that we can kind of be looking downrange at what you guys might be putting out there for public comment?
So the big ones that are coming up, Chris, that will go out when they're the ones that are getting close, right? So I can tell you that we have a bucket of them, and many that kind of need review and need to be brought up sooner rather than later. There's the background check directive, right? There was a focus group, so that is nearing completion to be put out for public comment that you guys will want to pay attention to. As a reminder, that was put out for public comment. Y'all commented an awful lot, and it was re-looked at, and so it's going back out, but it'll go back out for public comment again. There's the whole policy around critical incidents or all incidents, right? Meaning abuse, neglect, critical incident, and death. It will need to align with the new incident management system as well as alignment with HHS's policy. So that's going to be coming out in the coming few months, right? Would you agree with that, Ann? I mean, we're kind of at a sticking point right now because we're waiting on HHS to update some of their policies so that it kind of aligns.
Yes, I think that should be coming out within the next couple of months.
Yeah, in the next few months. Obviously, Mary talked about the ones related to cost reporting and the cost allocation plans. We are looking at many that are no longer needed and trying to make them obsolete. Like the 4 that went out for public comment this month, right? I think that public comment ended last Wednesday. I think 3 of them were directives that we made obsolete. And then there was a minor change to 1. So we're trying to kind of look through ones that we think we don't need to have out there anymore. Many of the directives that we had, as you know, we put out there because we were the provider of record, and it was kind of like our way of trying to control how services were delivered. So I think that's what you'll see with some of those. There's going to be a change to the appeal reconsideration directive, but and that should come out in the next month or so. I don't think it's going to affect you guys as much. It's more about how we do business. We're trying to be a little more clear in the directive about when days start to be counted and things like that. So those are the ones I can think of right now. Does that help?
Yeah. Do you have the room and board directive on your horizon or on your radar?
Because that directive is assigned, every directive has kind of a document manager in our world. Like policy ones, waiver ones are assigned to me. Anything related to operations is assigned to Janet. Anything related to fiscal is assigned to the CFO. So I would doubt that we'll do anything into it until we have somebody permanent in the CFO position. Is that fair? I'm asking Constant.
Oh, yeah.
Yeah. So not quite yet, but we can make sure it's online for something soon that we look at that point.
So, again, the finance groups identified that as one that we're really concerned about.
Have you guys made
and
comments on
we're-
it?
Well, we're talking about meeting as a group and putting forth our recommendations to DDSN so that you guys can look at kind of what
That'd be
our
great.
concerns are. Yeah, I didn't know if y'all be receptive to that.
Yeah, 100%. I want to remind everybody that every single directive that is out there has a button beside it where you can make comments. If you got a problem with something and you think we need to do something about it right away, the best thing to do would be to submit the comments, especially Chris, like as a group. I think that would kind of lead us into what you guys are thinking that we need to do with it.
Okay, thank you.
You're welcome. All right, well, is there an updated contact list for who to call with what issues? I think we sent that out. Didn't we send that out at one point? I don't know. We can look at it again. I mean, kind of the easy answer is anything related to case management and waivers is me. Anything related to money is Mary. Anything related to programs, meaning day, residential, ICF is Janet. And we can get you to our staff if need be, but we can look and see if there's something we need to send out. I haven't lost any staff, and I know we did a whole, like, in case management, who to contact for what.
I think the other thing to know is that I believe that people who are fulfilling an interim role have access to their predecessor's
Yeah.
email account.
Yeah.
Or it's redirected. So if you send something to Quincy Swigert, Mary will get it. If you send something to Andrew Theron, Claire will get it.
Right.
And that's good for a while. At least that would make sure you got it to the right person the first time, and then eventually their email boxes will go away. But it takes a while, a couple of years usually.
Somebody said they were late. Was the ICF rate change payment update mentioned? I'm not sure what that means. You're talking about direct billing, ICF?
I think I
I'm guessing
understand,
she means the
Lori.
retro payment.
Right. The
Say
fee
again?
was never updated last fiscal year, I don't think, still, maybe?
Yeah, we haven't gotten a rate increase. When we get a rate increase, we update it, right? I know I checked with Quincy at one point about rate increases for ICF, and he was able to pull the memo that increased the rate the last time we got a rate increase. So if you think a rate increase happened that we haven't passed to you, if you will send me what that rate increase is, I will look into it. But our understanding is we have not had an ICF rate increase since, I want to think it's 22, right? 7/1/22, maybe. I don't know. I can't remember the exact date, but just whatever you think wasn't passed, if you'll send it to me, I'll get with Mary. We'll look into it.
Yeah, Quincy confirmed that we would get the rate increase, but I think he was waiting for the money to come in from DHHS to pass the actual cash along.
Yeah, if we don't see the increase, we can't give you an increase until we get the increase. So I don't know if something was posted, but that rate has not been passed to us yet. That could have happened.
Yeah,
That's
to my
happened.
knowledge, we didn't get last fiscal year as in 24, and I think there's some from 23 even sitting out there. So
We
we
didn't
have all those
get, I don't
numbers.
think
So-
we got an increase in 24.
Okay, well, we'll certainly get that over to you.
Yeah, just send it to me, what you think happened, and I will look at it compared to what we've passed.
Corey, this is Chris again on the directives. I'm looking at your website. There's a fiscal year 2024 list of policies, directives, standards for committee review. Will you guys be updating that page for 2025?
We have talked about it. I'm gonna meet with the policy committee, because here's the truth about what happens. We always kind of have this, what we think we're gonna update, and then what happens is we don't update a large portion of that because we have to update the stuff that needs to be updated based on other changes within the system. Like if Medicaid makes a change, a lot of the fee-for-service stuff. So, you know, even if we update it, it's not the end all be all. Again, if you have a directive that you would like looked at, make comments on the directive. That's a good way to get it started. All right. Thank you guys for coming.